Laptop, grab your earphones and let's go. Hello and welcome back to the YouTube channel. My name is Dr. Moses Kazevu and this is MK's Medical Review Series. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be starting a new series on the channel. This is known as Hospital Basics, but because it's Cardiac Week on the channel, we shall start looking at heart sounds and pretty much murmurs. So if you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. And let's jump right into the topic. I have realized that there are quite a number of students that come to the hospital from preclinical sciences and really do not know the basics of heart sounds and find it very difficult to distinguish the normal heart sounds from the abnormal heart sounds. That's how I thought that I should put together this mixture of different heart sounds and this concoction that I've made for you today that will help you learn the normal heart sounds together with the abnormal heart sounds. So I hope you're really ready, and I hope by the end of this lecture you would be able to distinguish normal heart sounds from abnormal heart sounds. Remember that the heart sounds are going to be heard during auscultation, which is going to be performed during a cardiovascular exam. Remember, whenever you're examining any system, we follow a schematic in medicine, the IPPA: inspection, palpation, percussion, and auscultation. So you inspect, then you touch, then you percuss, then you listen. You auscultate using your stethoscope. So when you listen to the heart sounds, you should always note whether the heart sounds are normal. You should also always note whether the heart sounds are abnormal. And when you're talking about abnormal sounds, they could be heard directly from the heart. You refer to that as a murmur, or you could hear what is referred to as a pericardial rub, which is due to pathologies affecting the pericardium. You could also hear abnormal sounds from blood vessel. You refer to those as bruits. The tool that you're going to be using to actually listen to these heart sounds is known as a stethoscope. You pretty much carry around the stethoscope. I see most of you hanging it around your necks, and it is pretty much the medical students and the doctor's jewelry. So it pretty much has predominantly two parts, the headset and the chest piece. So the headset is going to contain of the metallic tube and of course the earpieces, and then of course there'll be a flexible rubber tubing which is connected to the chest piece. The chest piece predominantly has two parts. There's what is referred to as the bell, which is this small aspect here which has a tiny hole, and a diaphragm. If you're using a stethoscope that has a bell and a diaphragm combined, they will both be on the same side. But most of the stethoscopes are going to be having a bell on the opposite side and a diaphragm on the opposite side. So you can pretty much twist this tubing and you hear a click sound to tell you that you're now listening to the bell or you're now listening to the diaphragm. And remember, why do you have these two different parts? The diaphragm is going to help you pick up high-pitched sounds, whilst the bell is going to help you pick up low-pitched sounds. So diaphragm, high-pitched sounds, the bell, low-pitched sounds. Now, before we actually go into the different heart sounds, there are different basics that you really need to know. Remember that when you're auscultating, you're going to be doing it in a schematic and rather following a certain scheme. So you're going to be starting from a certain point and you're going to be finishing at a certain point. So there are four main areas that we'll listen to where we can best hear the different valves of the heart. So beginning with the first heart valve, remember that there are four predominantly valves in the heart. You have the valves that are between the atria and the ventricles. You call those as atrioventricular valves. Mainly on the right side, you have the tricuspid valve. On the left side, you have the mitral valve. The mitral valve is also referred to as the bicuspid valve. Then you also have valves between the ventricles and the great vessels. So between the left ventricle and the aorta, you have the aortic valve. That's on the left side. Between the right ventricle and the pulmonary trunk, you have the pulmonic valve. That's on the right side. So you have right-sided valves. Predominantly, those are going to be the pulmonary valve as well as the tricuspid valve. You have left-sided valves, which are pretty much going to be the aortic valve and the mitral valve. So each of these can be heard at specific areas on the chest of an individual. So let's look at this diagram here on the right of the screen. So this is going to be the right side of the patient. This is going to be the left side of the patient. So this area here, the second intercostal space right of the sternal edge, if you place your stethoscope in this area, you're going to be listening to the aortic valve. If you place it on the same exact area opposite on the left, so meaning second intercostal space left of the sternum, you're going to be listening to the pulmonary valve. So this is where you're going to be listening to the pulmonary valve from. Then if you descend and you go to the fifth intercostal space, so if you're counting the first intercostal space, second intercostal space, fourth intercostal space, fifth intercostal space. So if you put it at the fifth intercostal space on the left of the sternal edge, you're going to be listening to your tricuspid valve. And then of course the mitral valve is where you find your apex beat, so your mid-clavicular line, fifth intercostal space. So this is where you're going to be listening to your mitral valve. Now there is a mnemonic to help you remember the different areas and the different valves that you're going to be listening to. Remember, all physicians take money, if you really love money like I do, or all physicians take milk, if you love milk also like I do. So depending on whatever you're going to be remembering very well, all physicians take money versus all physicians take milk. Or you can just say all players take milk, all players take money, whatever you want to remember. Those are going to be the areas that you're going to be auscultating. So keep this in mind, because it becomes very, very important, especially when you're examining the patient and it becomes a practical thing rather than the theory and you just learning these things on the slides. So what's the procedure that you're going to be following? So the first thing that you're going to be doing is you would have already done your inspection, you would have done your palpation, and then we rarely percuss the cardiovascular system. We move on straight to auscultation. So when you are now reaching the auscultation part, you're first going to be listening to all four areas of the heart using your diaphragm. So you place your diaphragm firmly across the aortic area and listen there for some time. Don't just place it there and then move it quickly. Make sure that you take your time and you actually listen to the heart. A nice clinical hack is you should also be able to palpate the radial pulse or even the carotid pulse at the same time as you're listening to the heart, because this will help you identify whether you're hearing a normal sound versus an abnormal sound. When the heart beats, and you should hear something from your stethoscope. When it's not beating, you should hear something depending on whether it's systole or diastole, whether it's S1 or S2. So you're going to be placing your stethoscope at the aortic area. Then you move the diaphragm and place it across the pulmonary area. Do the same thing. Keep palpating the pulse and listening to this area of the heart. Then you move to your tricuspid area. Then you move to your mitral area, like that. So when you get to the mitral area, you're going to be switching now and switch your stethoscope and listen with the bell. Remember that the bell is going to be helping us picking up low-pitched sounds. So you're going to ask the patient to turn to their left side. So they should turn to their left lateral decubitus position. You refer to this as an accentuation maneuver. The reason why it's called an accentuation maneuver is because it's going to help you identify sounds that weren't loud enough, because they will become loud enough. So this is going to help you identify a mid-diastolic murmur that may be evident of mitral stenosis or any mitral pathologies. Also ask the patient to take a deep breath in and then deep breath out and then hold their breath. Then listen to the mitral area. Also listen to the axilla. In case of a murmur that may be radiating to the axilla, do not forget to listen to the axilla. Now, with your same bell of the stethoscope, remember that your bell now will be here at the mitral area. You can now go backwards. So with the bell, listen to the tricuspid area, listen to the pulmonary area, listen to the aortic area. Then you'll be back to these two areas here. Then you switch it back to the diaphragm and listen to the aortic area. Ask the patient to lean forward. It's also an accentuation maneuver for aortic pathologies. Ask them to take a deep breath in and out, then hold their breath as you're listening to this area. Then, of course, you do the same thing from the pulmonary area. And do not forget to auscultate for the carotids in the neck to pick out any murmurs that are radiating to the neck, any bruits that are radiating or that are present in the neck, rather. A bruit, this is pronounced as bruit, not brutes. So bruit, you're going to be listening to those over blood vessels. Okay, so like I already said, that there are some maneuvers that are known as accentuation maneuvers. Like, for example, laying on the left side helps with the mitral regurgitation, making the murmur more evident. Inspiration helps to hear tricuspid regurgitation. Leaning forward helps with aortic regurgitation and pulmonic regurgitation. You may also hear some frictions and venous hums. These are often best heard on maintained expiration when the patient is leaning forward. So they're going to hear these as high-pitched scratching noises that are going to be audible during any part of the cardiac cycle and over any part of the left precordium. Then, of course, you may hear hyperkinetic venous hum that is often heard at the base of the heart and particularly very common in infants, and it usually disappears when they are laying down flat. So before I actually go into details of the different sounds that we're going to be listening to in this PowerPoint, so please watch the video till the end. If you're not using headsets, please get your headsets because you're going to have a much better experience listening to these heart sounds when you are using your headsets. So let me just go to a black screen here so that I can explain this very well so that you do follow what I am talking about. So let me just show you a black screen. Okay, let me get a pen. I think this time I'm going to choose green. Okay, let's go with green. So remember that you have a cardiac cycle. The cardiac cycle is pretty much going to be composed of systole, so SYS. Okay, this is where the heart is going to be contracting, and it's going to be consisting of diastole. Okay, this is where the heart is going to be relaxing. Okay, so there are different phases of systole. There is isovolumetric contraction. You have the rapid ejection phase, rapid ejection phase, and then you also have other phases in diastole, like for example the early passive filling, the late passive filling of the heart. But I won't go into details of the cardiac cycle because that is a separate lecture in physiology on its own. But for now, for basics, just remember that the heart has predominantly two phases: a phase of systole and a phase of diastole. Okay, so the phase of systole, that's where contraction is going to be happening. The phase of diastole, that's where relaxation is going to be happening. And remember that we have valves that are between the atrium and the ventricles, so you refer to those as atrioventricular valves, so the AVs. So these are known as atrioventricular valves. So you have predominantly the mitral valve, and you have predominantly the tricuspid valve. So the mitral valve and the tricuspid valve. Then you have the other valves, which are pretty much the pulmonic valve and the aortic valve. Okay, so predominantly 4 valves. Okay, so when the heart contracts, remember that these sounds of the valves are made by closure of the different, these heart sounds are made by closure of the different valves. When the valves close and close, they send vibrations throughout the surrounding tissues, and these vibrations are what we hear as the heart sounds. Okay, so you have S1 here. Okay, S1 is going to be denoting the closure of the atrioventricular valves when the heart is going to be contracting in systole. So when the mitral valve and the tricuspid valve are going to be contracting, that's what is going to be causing systole. That's what's going to be causing the S1 heart sound, the lab first sound. So this is what's going to be heard as the lab. Okay, so this is S1. So this is going to be due to closure of the atrioventricular valves, so the mitral valve as well as the tricuspid valve. So then you move now into, so remember that whenever these atria contracts and pushes blood from the atrium to the ventricles, then this is the phase of filling. Okay, at this point you have, so where I've started off from, you have blood that's now present in the ventricles. The ventricles are supposed to contract, okay? And as these ventricles are supposed to contract, the valves that are leading to the atria are supposed to shut close, okay? So it means that this helps prevent backflow of blood into the atrium. So as now the ventricles begin to contract, the aortic valves, the mitral valve and the tricuspid valve are supposed to shut close. So this is what creates the first heart sound. Okay, now the second heart sound here. So now remember that at this point you have opening of the aortic valve, you have opening of the pulmonary valve because blood is now being pushed out of the heart between S1 and S2. Okay, now the second heart sound, remember that now the heart is relaxed. Now the blood is now in the large vessels, the aorta and the pulmonary trunk. Remember that these vessels, when they receive blood, they distend and they're elastic. So when the heart relaxes, these blood vessels also aim to return back into their normal position. So it means that there is a column of blood. There is some pressure that's exerted on the aortic valve and the pulmonary valve. And then these valves are supposed to now shut close so that they prevent a backflow of blood into the ventricles. So that's what's going to be creating the second heart sound. This is what's known as the dub. Okay, so this is what's known as the dub. So you have the first heart sound here, which is due to the closure of the atrioventricular valves. That's the mitral valve and the tricuspid valve. You have the second heart sound, which is due to the closure of the pulmonary and the aortic valve. That's what gives you the S2. And then, of course, this is later following an S1. So between S1 and S2, you refer to that as systole. Between S2 and S1, you refer to that as diastole. The heart is relaxing, meaning that if in between these two sounds, there should be silence. So there shouldn't be any sound here. So there should be a sound that's happening here. So you have a sound that's happening here. Then, of course, there will be silence that's going on. Another sound that's happening here, another sound that's happening here, followed by silence. Then, of course, this should be followed by another sound here. So that's the S1. So as you can see, I've drawn the S1 is S1 here, and of course S2 here, then another S1 here, which is similar to this other S1. So there should be silence in between the sounds. Between S1 and S2, there should be silence. Between S2 and S1, they also should be silence. So meaning that if you have any sound that is occurring between these phases, you refer to those abnormal sounds as murmurs. So if the murmur is occurring between S1 and S2, you refer to that as a systolic murmur. So this is going to be a systolic murmur. If a murmur is going to be occurring between S2 and S1, you refer to this as diastolic murmurs. Now, depending on where the sound is actually going to be located, if the sound is going to be closer to S1, you refer to that as an early systolic murmur. If it's going to be closer to S2, you're referring to that as a late systolic murmur. If it's going to be in the middle, you're going to be referring to that as a mid systolic murmur. If it's throughout, you don't hear any silence here, but you hear a sound throughout, you refer to that as a pansystolic murmur or hollow systolic murmur. Same thing or similar thing is happening with the diastolic murmur. There could be early diastolic murmurs, mid diastolic murmurs, and pre-systolic murmurs, or you can call them late diastolic murmurs. Okay, so these are the different systolic murmurs and diastolic murmurs. This is just the basic principle. I hope it's still very, very simple for you to understand, because once you understand this basic concepts, then it makes understanding murmurs very, very easy. So now let's go back to the different valves. So we have mitral valve, tricuspid valve, aortic valves, and pulmonary valve. Now remember that these murmurs are made by closure of the valves. So the heart sounds, normal heart sounds rather, are made by vibrations that are set off through the closure of the heart valves. Okay? Opening of the heart valves must be smooth. There shouldn't be any sound that is heard. So it's silent. When the heart valves are open, it will be silent. So let's see now which valves open at which stage, which valves close at which stage. So we begin with S1. Okay? So what happens at S1? So remember that S1 here is going to be due to closure of the AV valves. So the AV valves here will be closed. Okay, so the mitral valve will be closing, the tricuspid valve will be closing. So meaning that if there is any problem with the closure of the valve, meaning that if the valve is not closing well enough, it's insufficient, you're going to have a characteristic abnormal sound that's going to be created. So meaning that mitral stenosis and tricuspid stenosis are going to give you systolic murmurs, because the problem is going to be with the contraction. So this is going to be, not stenosis, rather, apologies for that. Oh, what have I done? So apologies for that. It's supposed to be regurgitation. Let me draw that screen back. Apologies for that. So S1 over here, and then you have S2 over here, then you have another S1 over here. So apologies for that. It was supposed to be regurgitation because that's insufficiency in inability to close very well. So it's supposed to be regurgitation. So S1, we say that the atrioventricular valves are the ones that close. So you're going to be having mitral regurgitation being a systolic murmur. You're going to be having tricuspid regurgitation being a systolic murmur. Okay, I hope that's now corrects the mistake I made earlier on. So the other valves that are here are the aortic valve. So the aortic valve and the pulmonary valve are supposed to open, because remember that during systole, blood is supposed to move from the ventricles. It's going to be moving into the great vessels. So these valves are supposed to open. And remember that the opening of these valves is supposed to be without a sound. So if there is a sound, it means that there is a pathology that's going to be there. Now, what can cause the valves to not open very well? It's if they become calcified, if they become stenosed, they become narrow. So it means stenosis can result in systolic murmurs. So aortic stenosis and pulmonary stenosis. So these are the four characteristic valvular lesions that are going to be giving you systolic murmurs. So mitral regurgitation, tricuspid regurgitation, aortic stenosis, and pulmonary stenosis. These are going to be preferably giving you systolic murmurs. Okay, so they're going to be heard best at systole. Then on the other hand, S2 here, remember at S2 here, this is where now diastole is going to be happening. So filling is supposed to be taking place. So it means the atrioventricular valves in this phase are supposed to open. So the AV valves are supposed to open. So remember that if they are stenosed, they're not going to be opening very well. So it means pathologically, there's going to be a sound that's going to be heard. So it means that mitral stenosis and tricuspid stenosis are going to give you diastolic murmurs. On the other hand, this is supposed to be stenosis, not regurgitation. Stenosis S. I don't know why I keep making the same mistake. S. Then on the other hand, the aortic valves and the pulmonary valves are supposed to close. So remember, if they do not close well, you call that as regurgitation. So it means that the aortic regurgitation and pulmonary regurgitation are going to be giving you characteristic diastolic murmurs. So these are the murmurs that we're going to be looking at. In addition, we're also going to look at certain murmurs that are going to be affecting the children or individuals with atrial septal defects, ventricular septal defects, as well as mitral prolapse. But predominantly, these are the main murmurs that you need to look out for. The systolic murmurs are these: mitral regurgitation, tricuspid regurgitation, aortic stenosis, pulmonary stenosis. Then the diastolic murmurs are mitral stenosis, tricuspid stenosis, aortic regurgitation, and pulmonary regurgitation. Now, before I actually move on, normally, when someone inspires, remember that the valves that are on the left side are going to be closing much faster than the valves that are on the right side. But because the first heart sound, the closure of both the mitral and the tricuspid happens within a short space of time, that's why we hear the first heart sound as only one sound. But ideally, they are two different sounds: the closure of the mitral and the closure of the tricuspid. With the second heart sound, which is due to the closure of the aortic and the pulmonary, these can be split, what is known as physiological splitting. So the second heart sound can be split into two components, especially when someone takes a deep breath. It can be split into the first component, which is known as the aortic component, where the aorta is going to be closing. So this is the A2 component. So this is the aorta, and the pulmonic component, which is the P2. So this is normally happening during inspiration. This is known as physiological splitting of the second heart sound. So sometimes you may have a widened splitting of the second heart sound. You may have reverse splitting. All those things are going to be different pathologies that we will look at during the course of Cardiac Week. So I hope this gives you a very good explanation and the basics of heart sound. So now let's go through the PowerPoint and actually listen to the individual heart sounds. So before we actually go there, I will give you 3 seconds to actually look through this on your screen right now and actually digest what is happening on your screen. And also, as you are digesting what's happening on your screen, do not forget to subscribe to the channel. It does really help the channel, and if you drop a like, it also does really help the channel much further. So let's get now to the PowerPoint and see what the PowerPoint has to say. So there are two sounds that are normally heard through a stethoscope during each cardiac cycle. And remember that the heart sounds are going to be produced by vibrations that occur during closure of the heart valves during the cardiac cycle. Opening of the valves should not produce any sounds unless there is a pathology. Then normally the valves on the left side are going to close first as compared to the valves on the right side, and the valves on the right side are going to open first as compared to the valves on the left side. So those are the normal principles that you should keep in mind that I have already explained. So speaking of the first heart sound, this is going to be a low, slightly prolonged lab first sound caused by vibrations of sudden closure of the atrioventricular valves at the start of systole. So it's going to be closure of the mitral valve, closure of the tricuspid valve. Now, because the separation is only about 0.01 seconds, the human ear can actually not appreciate the difference between the two closures of the aortic and the tricuspid. So that's how we hear it as a single sound. So the first heart sound is also known as S1. So I hope now you understand why they write S1, S2 on the different files that you see at the hospital. Then, of course, the duration of S1 is going to be 0.15 seconds and the frequency 25 to 45 hertz. Is this important for you to know? Yes, they do ask you these things on your multiple choice questions. So S1 is going to be soft when the heart rate is low, because the ventricles are going to be filled with blood and the leaflets are going to be floating. So they'll be much closer to each other. So there won't be a great distance for them to close. So remember, the greater the distance between the valves, the more they have to travel, the force is much greater. So it means the vibrations will be much greater. S1 will be much louder. So it means if the heart rate is fast, then S1 is going to be much louder. If the heart rate is slow, it's going to be much slower because the valves will be floating almost close to each other, and when they close, they only travel a very short distance. I hope that's making some sense. So moving on to the second heart sound, this is going to be much shorter and high-pitched dub sound that's going to be created by vibrations of the closure of the aortic and pulmonary valves, and S2 lasts for 0.12 seconds. Remember, S1 0.15 seconds, then the frequency of 50 hertz. So S2 is loud. Remember, S1 was soft, and it's going to be sharp when the diastolic pressure in the aorta or the pulmonary artery is elevated, causing the respective valves to shut briskly at the end of systole. So this is what makes up S2, the vibration sent by the closure of the aortic valve and the pulmonary valve. Okay, so you may sometimes get physiological splitting of the second heart sound. So the interval between the aortic and the valve, a pulmonary valve closure during inspiration. So the second heart sound is going to be duplicated into two components. A first component, which is known as the aortic component, a second component that's known as a pulmonic component. And when the person is expiring, the sound is actually heard as one. When the person inspires, there's going to be an increase in cardiac output. There's going to be an increase in the output from the right heart, so it's going to be physiological splitting. Some conditions may cause splitting of the second heart sound, such as pulmonary stenosis, atrial septal defects, the left to right shunts, and of course advanced aortic stenosis. Here are some pathological examples of S2 splitting. So as we can see here, this is a widened splitting of the S2 heart sound that's seen in pulmonary stenosis and right bundle branch block. A fixed splitting where there's a fixed distance. This is known as atrial septal defects, the left to right shunts. And then of course you have paradoxical splitting where the P2 components comes before the A2 components. This is seen in left bundle branch block and advanced aortic stenosis. But of course, if you do not understand this at this point, we will talk about each of these topics individually during the cardiac week. So please just hold back and relax. Just enjoy the video. For now, I want you to learn the basics. So now here comes the interesting part of this video. Here comes the actual heart sounds, where I would now want you to get your headphones and actually listen to this very closely. So here is a recording of the first heart sound, which is a normal heart sound. Remember S1, S2, S1, again, S2. So this, now I will keep quiet and have a listen to this. So I hope you can tell the difference between the lub and the dubs. Lub, dub, lub, dub. I'll keep playing that again. Okay, so that's what a normal heart sounds like. You can actually listen to your own heart. Assuming that you have a normal heart sound, then you will be able to hear a sound that is much, much similar to the one that I've just played. Okay, so now let's move on further. We now go to the third heart sound. So this is also known as S3. We're now getting to some pathological sounds. S3 is not always pathological, but it is pathological in certain conditions. So in about a third way through diastole, you may hear an added sound. This is very common in normal young individuals. This is like a soft, low-pitched third heart sound. This is going to be coinciding with rapid ventricular filling. Remember that filling of the ventricles happens in diastole. In early diastole, you have early passive filling. The atria are not contracting. Then in late diastole, you have a rapid filling where the atria contracts. So this is now due to the vibrations of the inner rush of the blood, you may create a third heart sound, which has a duration of 0.1 seconds. In young individuals, this is normal. In adults, this is going to be pointing you towards volume overload and often is a sign of cardiac disease. S3 heart sounds are heard in heart failure. So here is an S3 heart sound. So I'll play the normal sound first. Now I'm going to play the S3 heart sound. So notice how between S1 and S2, there is silence, but between S2 and S1, there is a sound that you can hear. So I don't know if you can pick that up, but pay close attention. That's a normal heart sound. It's almost like as if the third heart sound is fusing with the second heart sound. Okay? So that's an S3 heart sound. I will play it again so that you can actually keep it in your mind. Okay, so now we will move on to one last time. I hope you got that in your brain. So now let's move on to the fourth heart sound. So this fourth heart sound can be heard immediately before the first heart sound. So it will be much closer to S1 than S2. Remember, S3 is going to be much closer to S2 than S1, but with S4, which is the fourth heart sound, this is going to be much, much closer to the first heart sound. So this is going to be due to the atrial pressure that is high or a ventricle that is stiff. So if there is ventricular hypertrophy and it's due to ventricular filling, and it's rarely normal, it's rarely heard in normal adults. So it means if you hear it in an adult, there is a pathology that is there. Sometimes this S3 and S4 heart sounds, if they're heard in combination with S1 and S2, it kind of sounds like horses that are running on, and you can see that you can picture the sound of horses in a movie that are trotting across. You refer to that as a gallop rhythm. So you may sometimes hear a gallop rhythm. So I will play you the normal heart sound first, then I'll play you an S3, then I'll play you an S4 heart sound. So this is a normal heart sound. And this is what an S3 heart sounds. Now note the difference with an S4 heart sound, which will be much closer. Remember, the S4 component will be much closer to S1 than it is to S2. Now note the difference between the S3 sound and the S4 sound. Oh, I was playing the normal heart sound, sorry. So note the difference between the S3 sound and the S4 heart sound. Okay, if they're confusing you, just rewind the video back, read the text, understand the text, and listen to the sounds again. It will make sense. That's a S4 heart sound. Okay, now here's a summary of everything that we're talking about up to this point. So the first heart sound is due to vibrations from the closure of the atrioventricular valves. It's going to have a duration of 0.15 seconds and a frequency of 25 to 45 hertz. So it's going to be prolonged and it's going to be a soft lab. The second sound is due to the vibrations from the closure of the semilunar valves, the Iotic and the pulmonary valves. It will have a duration of 0.12 seconds and 50 hertz frequency, and it's going to be short, high-pitched dub, and can undergo physiological splitting during inspiration into two components, an Iotic and a pulmonary component. And the third heart sound is due to rapid ventricular filling. It has a duration of 0.1 seconds. It's going to be heard 1/3 through diastole, so it's normal in young individuals. In adults, it is pathological and a sign of heart failure. S3 is going to be much closer to S2 than it is to S1. S4, on the other hand, is due to high atrial pressure or ventricular stiffening, such as in ventricular hypertrophy. It's rarely heard in normal individuals, and it's going to be much closer to S1 than it is to S2. Now, when you have these heart sounds in combination, all of these present on the screen, they may produce what is known as a gallop rhythm, like horses running across the ground. So now let's move on to murmurs. So those are the normal heart sounds, S1, S2, S3, and S4. Now we'll move on to abnormal heart sounds. So remember that a murmur or a bruit are pretty much abnormal sounds heard in various parts of the cardiovascular system. And even though the two terms are actually used interchangeably by many different people, they actually mean different things. A murmur is going to be denoting a noise that's going to be heard across the heart, whilst a bruit is going to denote a noise that is heard across the blood vessels. Recall that blood flows in a smooth, laminar, and a non-turbulent way, meaning that it is silent up to a certain critical velocity, up to a certain speed. Beyond this velocity or beyond this speed, or beyond an obstruction, then the blood flow becomes turbulent and it creates a sound. So blood flow speeds up when an artery or even a heart valve is narrowed, and this is going to give you a certain characteristic valve. Same thing happening with a valve that's insufficient. It may give you a characteristic sound when it's supposed to be closed and it doesn't close entirely. There may be a jerk of or a flashback of blood back to where it is coming from. And remember that a cardiac murmur or heart murmur is going to be produced when blood is flowing across one of the heart valves that are loud enough to be heard with the stethoscope. So what are the types of murmurs? There are predominantly two types of murmurs. I recall back in my exam at 5th year when a lecturer actually asked me about the different types of murmurs, and I looked bewildered because I had never heard of them and I had never come across the different types of murmurs. So recall that there are anatomical murmurs and there are physiological murmurs. The anatomical murmurs are due to structural defects in the heart. They can be produced by narrowing or even leaking of the valves. So narrowing, you refer to that as stenosis. Leaking of the valves, you refer to that as regurgitation or insufficiency. Or they may be due to an abnormal passage through which the blood flows in or near the heart. For example, a patent ductus atriosum, or an atrial septal defect, or indeed a ventricular septal defect. Then, of course, the physiological murmurs, these are going to be heard primarily due to physiological conditions outside the heart, so there will be no underlying structural defect. And these physiological murmurs are often benign, so they are innocent murmurs. They are usually soft systolic murmurs, especially in children who have no cardiac disease. And of course, you may get a systolic murmur that are also heard in anemic patients as a result of the low viscosity of the blood and is associated with rapid flow. So there is no anatomical damage to the heart. So talking about anatomical murmurs, so remember that the major, but not certainly the only cause of cardiac murmurs is usually heart valve disease. So that's why we're going to be focusing a lot on heart valve or valvular pathologies, because these are the ones that are going to be producing these type of murmurs. Then when the orifice or the opening of the valve is narrowed, you refer to that as stenosis. The blood flow through it is going to be accelerated and it's going to be turbulent. Then when a valve is incompetent, then the blood flow through it there's going to be some backward blood flow, and there's going to be regurgitation. So this is going to create a certain sound. Then the timing of the murmur is due to where exactly it's going to be happening during the cardiac cycle. If it's happening during S1 and S2, or between S1 and S2, you refer to that as a systolic murmur, like already explained. If it's happening between S2 and S1, you refer to that as a diastolic murmur. Then, of course, the murmurs are also going to be occurring at a particular point of the chest. They're going to be heard best at particular points of the chest. So knowledge of this mechanical events that are happening in the cardiac cycle helps us to predict where the pathology is. And the murmurs due to disease of a particular valve can actually be heard generally best with the stethoscope directly over that same valve. That's the rule of thumb. And there are also other aspects of a murmur that you really need to know. So the duration, the character, accentuation, and the transmission of the sound. That also helps to pinpoint where the murmur is coming from. Here are examples, like I already mentioned: aortic, pulmonary, tricuspid, and mitral. So aortic stenosis is a systolic murmur. Pulmonary stenosis is a systolic murmur. Mitral regurgitation or insufficiency is a systolic murmur. Tricuspid regurgitation is a systolic murmur. Aortic regurgitation is a diastolic murmur. Pulmonary regurgitation is a diastolic murmur. Mitral stenosis is a diastolic murmur. Tricuspid stenosis is a diastolic murmur. So those are the predominant murmurs that we're going to be looking at. So functional murmurs, on the other hand, are primarily due to physiological conditions outside the heart. So these functional murmurs are benign, so they are innocent murmurs, and they are often soft systolic murmurs, especially in children who have no cardiac condition, and they never exceed grade 3. There's a specific grading that is done for the murmurs. I will give you that, I think, in the next slide. So here's the grading of the murmurs. So you have grade 1 up to grade 6. So grade 1, this is what I love to call a professorial murmurs, because it's only the professors that can apparently hear them. So these are murmurs that are barely audible. Okay, so these are barely audible murmurs. Then, of course, a grade 2, this is going to be a soft and localized murmur. A grade 3 is going to be a murmur of moderate intensity that is immediately audible. So it means that the systolic murmurs, they do not go beyond this grade 3. Then grade 4, the murmur is going to be of loud intensity. Then grade 5, a murmur of loud intensity with a palpable precordial thrill. A precordial thrill is just simply palpable vibrations that you can feel across the chest when you palpate. So it's a palpable murmur. Then grade 6 is, of course, just like as you have in grade 5, except you can even hear the murmur just if you lift your stethoscope above the chest, just off the chest wall, you can still hear the murmur. That's known as a grade 6 murmur. So how do we describe murmurs? We should first note the location of the maximum impulse point. I should note the timing, whether it's a systolic or a diastolic. Like I told you, a clinical hack is to feel for the pulse when you're auscultating the heart. If you feel the heartbeat and that's when you're hearing the sound, it's most likely a systolic murmur. If you don't hear the heartbeat and that's when you're hearing the sound, it's the diastolic murmur. Sometimes it can be throughout the entire phase of the cardiac cycle, both systole and diastole. Then the systolic murmurs could be mid-systolic or late systolic or pansystolic. Diastolic murmurs could be early diastolic, mid-diastolic, or pre-systolic. Then, of course, continuous throughout the entire cardiac cycle. And of course, you should also note the pitch. If it's a low-pitched, medium-pitched, or high-pitched murmur, the frequency of the murmur, of course, this you will not be able to tell, but you can tell whether it's a sharp or it's a dull kind of sound. Then, of course, the grading of the murmur, which I already talked about, so I just put it here for the purpose of emphasis. Then, of course, if the murmur is radiating to a specific structure, if it's radiating to the neck, if it's radiating to the axilla, or is it radiating to the back? So when you are describing murmurs on your cardiac exam, you should include all these things. If you hear a murmur, make sure that you will tick all these boxes for you to be able to score an A+ on your clinical exam. So we'll start with systolic murmurs. Remember, let me get back to the schematic that I had drawn much earlier on. So we have this here as our S1, followed by this here as our S2, followed by this here as S1 again. Okay? S1 again. So this is going to be the phase of systole. This is going to be the phase of diastole. Remember that here at S1, you're going to have the AV valves, atrioventricular valves, closing. So it means that if they do not close very well, if they are insufficient, you're going to get a systolic murmur. So meaning that the mitral regurgitation, tricuspid regurgitation are going to give you systolic murmurs. On the other hand, the other valves that are happening to be opening are the semilunar valves, the aortic valve and the pulmonary valve. And remember, we say that when valves open, ideally they shouldn't make any sound. If they make a sound, it means that there is a problem, and this problem is often narrowing of the valve. So it means that aortic stenosis and pulmonary stenosis are going to give you systolic murmurs. So the four predominant systolic murmurs are going to be mitral regurgitation, tricuspid regurgitation, aortic stenosis, and pulmonary stenosis. So the systolic murmur could be early, late, sometimes even mid-diastolic, depending on where you hear them on the cardiac cycle, and they may sometimes happen throughout the cardiac cycle. So you refer to that as, or throughout the systolic phase rather, you refer to that as a pansystolic murmur. So we'll start with, first of all, the differences between your early diastolic murmur and your late diastolic murmur and your pansystolic murmur. So this is an early systolic murmur. Okay, so it sounds like as if there's something blowing between S1 and S2. There's something that's happening. And it's much closer to S1. And this is a late diastolic murmur. I mean, a late systolic murmur. Sorry if I'm saying diastolic. I don't know why it's stuck in my mind. It's a systolic murmur. Note the difference between a systolic, an early systolic, and a late systolic. And this is now a pansystolic. You notice how there is no silence between S1 and S2. Here you can hear some silence. You can also hear some silence here. But here, no silence at all. So those are systolic murmurs. Examples. So play the video backwards if you may. Rewind it, pause it, understand the concept. Okay, sorry about that. So now let's go to now the individual systolic murmurs. So let's talk about mitral regurgitation. Remember that here, the mitral valve is supposed to be closing when the ventricles are contracting, the left ventricle to be specific. So this is going to be preventing blood from backflowing into the atrium. So if the valves are insufficient, and they're allowing blood to flow back into the atrium, then it's going to create a sound during systole. So the sound of mitral regurgitation is going to be a soft S1, and these may sometimes be a wide split S2. This is often due to incomplete apposition of the valve cusps and partial closure by the time the ventricle begins to contract. And then, of course, the murmur that's characteristic with mitral regurgitation, you get a pansystolic murmur, or holosystolic murmur that is heard best at the apex and radiates to the axilla. This murmur every student should know. A pansystolic murmur heard best at the apex and radiating to the axilla. This is going to be occurring in regurgitation. So this is going to be happening throughout the entire systole. It may also radiate to the upper sternal borders or the subscapular region. And sometimes when you have a floppy mitral valve, there may sometimes be a mid-systolic click, which is produced with the sudden prolapse of the valve. I will play you a clip of how mitral valve prolapse sounds like. But for now, no, you may have a mid-systolic click. Then you may sometimes hear an S3 heart sound, which is due to sudden rush of blood back into the dilated left ventricle. Remember, I already played you what an S3 heart sound sounds like. So here's a characteristic murmur of mitral regurgitation, pansystolic murmur. And this is what a normal heart sounds like, in case you forgot. And this is what a murmur of mitral regurgitation, which is holosystolic, so throughout S1 and S2. I really hope that makes sense. So I will play it again, this since it's halfway. So note how you can't even hear any silence between S1 and S2. Okay, so that's mitral regurgitation. Okay, that's a normal heart sound. That's mitral regurgitation. Okay, moving on to tricuspid regurgitation. This is also going to be a blowing pansystolic murmur, burst heard on inspiration at the lower left parasternal edge. It's going to be similar to mitral regurgitation. The only difference that you're going to get here is where you're going to be hearing the murmur burst. So with mitral regurgitation, is going to be in the mitral area, radiating to the axilla. This is going to be best heard on inspiration at the lower left parasternal edge. That's a difference that you really need to know. Then moving on to aortic stenosis, this is also known as a diamond-shaped murmur. So it has a crescendo-decrescendo pattern. So you're going to have a high-pitched crescendo-decrescendo mid-diastolic murmur located at the aortic point that radiates to the neck. Okay. So this is with aortic stenosis. So this is a normal heart sound. And this is aortic stenosis. And do not forget the clinical hack I told you to be palpating and actually being able to tell where this murmur is occurring between S1 and S2 or between S2 and S1 and the location where it is. Remember, this is going to be heard in the aortic area, so that this will help you distinguish it from a mitral regurgitation murmur that's going to be heard at the mitral area. Okay, heard best at the mitral area and radiating to the axilla. So I'll play it again, aortic stenosis. Okay, that's a normal heart sound. Aortic stenosis. Okay. Now we move on to pulmonary stenosis. So this is going to be a harsh mid-diastolic ejection murmur that's best heard on inspiration at the left of the sternum in the second intercostal space where you have your pulmonary valve. And of course, you may have an ejection click. You may sometimes have a wide split S2. So the P component is delayed due to slow emptying through a narrow valve. Okay, so it's pretty similar to the murmur that you have of aortic stenosis. Then with diastolic murmurs, so what damn it's systolic murmurs. So that was the principle or the general outline or the general thought of systolic murmurs. So let's draw back our schematic here of S1 here, S2 here, then S1 again here. Okay, we already talked about the systolic murmurs. Now we are supposed to talk about diastolic murmurs. Remember here at S2, you're supposed to now have opening of the AV valves. So the atrioventricular valves are supposed to open. So what does this mean? If the valve is stenotic, if the mitral valve is stenotic, mitral stenosis, you get a diastolic murmur. If the tricuspid valve is stenotic, you get a diastolic murmur. Because remember that valves, when they open, they are not supposed to make a sound unless they are narrowed or they are calcified. That's when they will make a sound when they open. And then again, on the other side, you're supposed to have closure of the semilunar valve. So the aortic valve is supposed to close at S2. The pulmonary valve is supposed to close at S2 to prevent backflow of blood from the great vessels back into the ventricles. So it means that if the valves fail to close completely, if there is some insufficiency or regurgitation, then you get a diastolic murmur. So aortic regurgitation, pulmonary regurgitation are going to give you diastolic murmurs. Then the diastolic murmurs could either be during early diastole, mid diastole, or pre-systolic, or you can call them late diastolic murmurs. So here's an example of a diastolic rumble. Notice how you can pick out S1 and S2, and the sound is between S2 and S1. Okay, so now let's talk about the diastolic murmurs. So with mitral stenosis, if the mitral valve is still flexible or pliable, then there's going to be a loud first heart sound. If it becomes calcific and stiff, the sound becomes softer. And when the valve suddenly opens as the pressure or the force increases in the left atrium, is going to force the valve to open. So there is what is known as an opening snap. So this is going to be later followed by a low-pitched rumbling mid-diastolic murmur that is best heard with the bell of the stethoscope held lightly at the apex with the patient laying on the left side. So the P2 component of the second heart sound may be loud if, of course, there is pulmonary hypertension. Then, of course, if the patient is in sinus rhythm, the murmur becomes loud at the end of diastole as a result of atrial contraction. So you have what is known as pre-systolic accentuation. We'll talk about all these things when we talk about mitral stenosis. For now, I just want you to focus on how to pick up these different heart sounds. So here's a normal heart sound. And here is what mitral stenosis sounds like. So notice how the sound has the click in between. You may think like it's your headsets, but it's actually the click, the opening snap. And then just before S2, the sound increases in intensity. You call that as pre-systolic accentuation. Pay close attention to that. Okay. Now we'll talk about tricuspid stenosis. So this is a mid-diastolic rumble after an opening snap. It's similar to that of mitral stenosis, but this is going to be heard best at the left lower parasternal area, and it is heard best at expiration. And of course, it may be missed because the murmurs of tricuspid stenosis may coexist with the murmur of mitral stenosis. Then moving on to aortic regurgitation, this is going to be high-pitched early diastolic murmur that is best heard at the left sternal edge in the fourth intercostal space, with the patient leaning forward and breathing in, held in expiration. Then because of the volume overload that may sometimes be commonly seen, there's going to be commonly an ejection systolic flow murmur, and this is due to the regurgitant valve that can actually impinge on the anterior mitral valve casp, causing what is referred to as a mid-diastolic murmur or an Austin Flint rumble. So here is a aortic regurgitation murmur, and first of all, normal heart sound. And now the murmur of aortic regurgitation. Notice how it begins loud and then fades away. Okay, no more heart sound. Aortic regurgitation. So pulmonary regurgitation, here you have a decrescendo diastolic murmur, just like in aortic regurgitation. That's going to be beginning with the pulmonary component of S2. That is very difficult to distinguish from the murmur of that of aortic regurgitation. Now, you also have mitral prolapse. So those are the basic 8 murmurs that I want you to know as a student. And this is now the difference between A plus and an A. So you have the mitral prolapse. This is going to be a mid-systolic click, often followed by a late systolic murmur. And this is going to be the hallmark of mitral valve prolapse. This is what mitral valve prolapse sounds like. So that click you're hearing in between the S1 and S2, that's not your headsets having a problem, but it's actually the heart sound. Okay. Then this is what an atrial septal defect sounds like. And this is what a ventricular septal defect sounds like. Again, atrial septal defect. Ventricular septal defect. Okay, so this may be overwhelming, and the different sounds that you've heard up to this point, it may be overwhelming for you, but if you take your time and actually sit down and understand the physiology, understand the mechanics that are behind everything that I have played for you, then it will make a lot of sense and you'll be able to now identify specific sounds. Okay, so now here's a little test for you that I will play the sound and then I will give you time to figure out what the sound is about. So please keep score because it's out of 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There are 10 sounds that I'm going to be playing you here. And I will give you the answer after I play the sound. So please pay close attention. So here comes sound 1. So what do you think that was? You can shout at the screen now or you can write down your answer. And here comes the answer. So that's mitral regurgitation. Moving on to the second sound. What do you think that sound was? I know everyone at least is going to get 1 out of 10, so that's a normal heart sound. S4 heart sound rather. Sorry, that's an S4 heart sound. You see how you can easily confuse those things. And what sound was that? That's a normal heart sound. So note the difference between an S4 and a normal heart sound. If you're not listening closely, you can actually miss it. And this is a normal heart sound. Okay, moving on to now number 4. What sound is that? That's an S3 heart sound. Number 5. What sound is that? That's aortic stenosis. What sound is that? Mitral stenosis. What sound is that? Aortic regurgitation. What sound is that? A mitral prolapse. What sound is that? A ventricular septal defect. And then, of course, the last but not least, what sound is that? The only sound that is not on the list as an atrial septal defect. So get your score out of 10, and how much did you get out of 10? Comment in the section below, and here of course are the findings. So if you got a 10 out of 10, then that's pretty excellent of you. You are pretty good at heart sounds, and you have learned how to interpret or how to listen to the heart sounds. If you got 7 to 9 out of 10, you have a very good listening ear. If you got 5 out of 6, it's an average performance. You need to listen much longer and pay attention to the subtle changes in the heart sounds. If you got 3 to 4, that's of course below average. So take your time to understand the basic concepts of the heart sounds. And of course, if you got less than 3, then just rewatch the entire video slowly, because clearly you missed the whole point. But anyways, with that said in mind, from MK's medical review series, I hope you really enjoyed this video and you learned so much about the different heart sounds, the normal and abnormal heart sounds, including the different valvular pathologies and the different lesions. This is Cardiac Week. If you haven't yet subscribed, please subscribe to the channel, drop a like, drop a comment to show some support, share the link to someone who you think is confused about heart sounds and you think that this video may actually help to Zambia and beyond. My name is Dr. Moses Kazevu. Until